know kind of how this works. This is our quarterly town hall. And what we do is we do a moderated town hall format here so that we can get veterans' questions answered, so that we can not divulge anybody's personal or private information. What we do is a moderated town hall format. So we take questions via comment card, and Mr. Dave Martinez here is collecting those cards. So if you have a question, and if it's of general interest to the entire group, or something that we can talk about without divulging anybody's personal information or private information, we will try and do that here as part of a town hall. If it's something of a personal nature and it's a one-on-one issue we need to work, we have various specialists out here in the auditorium that can assist with that. And we will try and get you with one of them. If we don't have a specialist to work your need today, we will take your card and we will get back to you one-on-one. So the question will be answered in one way or another, either one-on-one or in general here at the town hall today, if it's a question of a general nature. So that's what we'll do. So like I said, Mr. Martinez is there and he has the comment card. So he will just raise your hand and he'll be happy to provide you one. So. All right, so before we get started, we want to just introduce a few of our special guests that are here today. We'll introduce the panel momentarily, but we have a great working relationship with our congressional delegation. So I would just like to recognize the members that are here today representing their principals. First, I'd like to introduce Mr. Bruno Moya, who's with the Office of Senator Dean Heller. Thanks, Bruno. Miss Alana Simpson, who is with the Office of Senator Catherine Cortez Masto. And Mr. Hunter Kane, who is with the Office of Congresswoman Dina Titus. So thank you for being here. Like I said, we have a very close working relationship. They are out there advocating for you guys every day and working with us to try and address your needs or your questions or your issues. So if you have a congressional type question, please reach out to one of these three, and I'm sure they'll be happy to help you. So before we get started here, I just will introduce our panel for today's town hall. First, we have the director of the VA Southern Nevada Healthcare System, Ms. Peggy Kearns. And then joining us, who is the acting director of the Reno Regional Office for Veterans Benefits Administration, Ms. Sheila Jackson, is on a detail in Washington, D.C. right now. But Ms. Teria Dowdy has joined us. She's up in Reno as the acting director for the regional office, so she's our Veterans Benefit rep today. So thank you, Ms. Dowdy. And last but not least, our Chief of Staff, Dr. Ramu Kamanduri, be part of the panel. And then I'd also like to introduce you to a couple of our other executive team members who are here in the audience today. We have Ms. Tracy Scala, who recently joined us. She's our new Associate Director. And we have Dr. Jennifer Strawn, who is our Nurse Executive and our Associate Director for Patient Care Services. So we are here to get this started. So what we're going to do is we're going to let the panelists kind of start this out. This is an educational informational session. That's what these town halls are for. So our panelists are going to kind of give you some updates on some various activities that are going on here at the VA, and then we will move into our moderated town hall format.
Good morning. Just wanted to take a little opportunity to give you some updates on some things that are going on here at the Medical Center. First, our facility was chosen as one of 8 cities to be part of the Veteran Suicide Prevention Initiative that was started by a private organization, SAMHSA, and the VA together. And so Mayor Goodman signed on to work with us and with the state, and a team went into Washington, D.C. about 3 weeks ago. And this team will be working on an initiative for not only the city of Las Vegas, but North Las Vegas, Mesquite, St. George, I think, a little bit of everybody in our whole area are going to be coming up with an initiative to help with our suicide in veterans. So that's kind of exciting. We were chosen because we were good partners in the 25 City Initiative for Homelessness. And we were one of only 10 out of the 25 that hit functional zero for homelessness. Now, that doesn't mean there aren't any homeless veterans out there, because there are. but we have vouchers that we could house them if they want to be housed. So that's why we were chosen, I believe, for the suicide prevention program, because we have a good community that works with us and helps us meet our goals. We were honored about a month ago, maybe a month and a half ago. Our surgical nurses were honored by they won the True North Award. I have to read this. They were awarded the True North Award, which recognizes our nurses for getting certification as surgical nurses. And this is a private organization that gives this award, and we are the first VA to win this award. So that's really a good, exciting thing. So we're really proud of them. It's from the Competency and Credentialing Institute that we got that with. So we were competing against over 600 facilities, and we won. So congratulations to our OR nurses. They give great care in the OR. We recently hired a new orthotist prosthetist. Say that 10 times fast. Difficult to say, but she is totally awesome. And we are doing some great things with limbs and things like that. She even has access available on the same day. So we're really excited about her. And during the day, we'll be playing some videos up here, and there is a video about what she's been up to. In the near future, we've got a lot of things coming up. Telehealth is probably the biggest thing that we're working on. This community, it's difficult to find providers, and so we're looking at every way we can to provide services. So we've recently started telecardiology out at Laughlin and Pahrump. We've started some telemental health, and Long Beach VA is providing the providers, and our veterans are able then to have mental health treatment out of Laughlin and Pahrump, where it's very difficult to recruit psychiatrists and psychologists. So those are some really exciting things that are happening. I'll let Dr. Comanduri talk about telestroke and tele-ICU and some of the other things that are going to be coming up in very, very near future. So thank you, everybody, for coming, and I'm going to pass it on to Terry.
Good morning, everyone. I will start with some of the initiatives with VA. VBA is to talk about first that we continue to use technology to leverage the opportunity to serve you better. We are definitely still focused on auto claims establishment. In the past, when we were in our paperless environment, we had a lot of restraints. It forced us to keep work, maybe where stations in various states did not have capacity. The more we really focused on becoming more paperless and being in an electronic environment, as we are full 100% in a paperless environment now, we have been able to improve service. So we continue down that path with ensuring that claims are now, even the mail is scanned in. So when we receive paperless documents in, they are shipped to our scanning vendor, and those are scanned in the system so that we can work all of the claims in a paperless environment. This has helped us in terms of making sure that as we use NWQ, our national work model, we're able now with NWQ to get claims in the hands of where there's capacity. So therefore, although you may be in Nevada, and hopefully I'm saying it right, I heard that I have to say that absolutely correct, I'm from Indianapolis. But if you're in Nevada, that if the Nevada offices does not have capacity, the agency with a click of a button can move 200 cases that may need a ready for decision. And we can move that work and maybe send it to Indianapolis where there is rating capacity. This has allowed us to go from a wait time that you all have experienced, and even some of your family members, from 6 months to now we're recording on average between 93 and 97 days on a rating claim. And I'm going to talk a little bit more about appeals reform, because some of the things we've been able to do with the rating workload, we now have the legislation to start working towards appeals. That brings me to the appeals reform. There's been legislation passed will help us to streamline our appeals process. Many of you may have heard about the ramp-in process. To date, we have sent out roughly nationally about 170,000 opt-in letters. And so I'm quite sure there will be questions about that. But I would tell you it does not deprive you or you don't lose anything. What we're trying to do with the appeals workload is we're trying to get you the same expeditious decisions we've been able to successfully do with the rating workload. We want to enhance that on the appeal side. The legislation is a barrier for us, and that is why the president signed into law some of the appeals modernization legislation, and we're very excited about it. To date, we are already receiving status updates that veterans that use the opt-in process are getting decisions in 51 days opposed to 3 to 7 years. And we know that's an issue, and we still have that legacy work there, but we are seeing improvements there. Finally, I would bring up an update regarding the Forever GI Bill, which was signed into law. And basically, the most significant change here is that we no longer have the 15-year limit, which I think is great. In the past, veterans had to work to utilize the benefit within a certain time period, and it would expire, and we no longer have that. I would think of all, and we have a lot of achievements that we're proud of, but I really want to highlight things that I think that you're most interested in. Thank you.
All right, good morning, everybody. Thanks so much for being here. I really appreciate it. I want to start with really, as you know, if you hear me talk, I always say, like, I try to tell you 3 things, and it's about all we can anywhere remember. So first, let's talk about the clinical care. What are we doing? Where we stand with clinical care, direct patient care? So as you know, as Ms. Kearns pointed out, it's very difficult to recruit folks. So we have worked hard and have added, fortunately, some staffing. So let's start with mental health. As you know, mental health is really our foundational service. We used to be, the VA has this ratio of having roughly 7 providers per 1,000 that they're trying to get to when it comes to mental health providers. And we were sitting at 4. So we really aggressively looked for mental health providers across the country. We've been actually approved by VA Central Office to actually provide loan forgiveness for psychiatrists, a good chunk of their loans being reduced so we can pay off a little bit of their loans from medical school, so to get them attracted. So this has helped us to attract. So we are pretty soon going to be able to finally reach our, at least the minimal ratio we need of mental health providers. So we've made a tremendous effort and transition in that area. So our access in mental health has significantly improved. Looking at the other specialty areas, in medicine, we've been fortunate enough finally to hire a sleep medicine doctor. As you know, we've been working forever to find a sleep doctor. So she's coming on board within the next month or so. We will be able to slowly, we'll hopefully develop additional support for the sleep program. So that's a positive step in the right direction. The other areas of medicine specialty that we've been working on is to, how do we develop a better support for a solid intensive care unit? As you know, we've been struggling to staff adequate number of both nurses and doctors in ICU and in the hospital wards and even the ER. So we've done lots of things to bring folks on. We brought on several critical care acute care nurse practitioners who have done a tremendous job. In fact, they're covering the ICU generally 7 days a week during the daytime. And we are now working with Minneapolis to build a tele-ICU program, which we hope to be up and running in September. So that will help us with the intensive care support, because it is just hard to find intensive care physicians. So the other areas that we're working on in the medicine subspecialties, we've continued to aggressively try to recruit additional staff. So in our cardiac cath lab has become a very busy cardiac cath program here. We want to really expand it. So in order to do that, we need to attract more nurses and subspecialty technicians. We're working on to recruit those folks. The other area to focus in on is surgery. At least we have some good news. We've hired a hand surgeon, which, as you know, is very difficult to find. It's a needle in a haystack to find a hand surgeon anywhere. Where in this town, it is almost impossible to find a hand surgeon, very few in practice. So we're fortunate to have her on board, and we've hired another orthopedic surgeon, which has also been difficult to find. It's a husband and wife couple, so they've come on board and have begun to work and begin to see these cases. Again, the volume is so high, we may not be able to get to everyone that needs here, so some of them will have to continue to try to use community resources. But I know our veterans prefer to come here. They'd rather get the care here, so we will do our best to bring those folks on. With regard to primary care, and that's another area where we are working hard to recruit and retain. Just so you know, we are one of the fastest top 10 growing VAs in the nation. 62,000 veterans, we're growing about 4% again. So if you look at every 1,000, every 1,200 roughly, you need a whole PAC team. So if you're adding, let's say, even 3,000, that you're looking at least a couple of PAC teams, if not more. So that is very difficult to add while you're struggling to just maintain the staff that you have. And that's just because of recruitment challenges. But we're working innovative approaches. We're doing some tele primary care within our own community, and there's VA nationally is looking at doing primary care from areas that are not growing to areas like us that are growing. So we'll see some innovations in that area. So those are the main clinical areas to talk about. The next area is our critical mission of teaching. Because of this VA, the School of Medicine, UNLV School of Medicine, has 3 major fellowship programs. They have a cardiology fellowship program because of our significant important role in building that, making that happen. They have a gastroenterology fellowship training program that would not exist without the VA. We've played a tremendous role in that. They have a critical care training program, which is, again, for running the ICU, pulmonary, critical care area. The good news is one of their graduating fellows, we're hoping everything goes right, and she'll join us at the VA in July, or probably August. So that is a very positive recruitment, which you desperately need for critical care support. So the teaching part. The other exciting thing to add is we're working with both UNLV and Toro and community hospitals like Sunrise and other hospitals in Mountain View to build a new fellowship program in rehabilitation medicine. This will be the first rehabilitation medicine fellowship program in the entire state of Nevada. And VA is going to play a critical care role in building that up. So we want to build the teaching so we can build the next generation of healthcare staff, bring them on board. And we have, Jennifer Strong can tell you, we have many, many affiliations with nursing programs we're building to grow here. Again, nurses are hard to find in this state. Tremendous difficulty recruiting, retaining both doctors and nurses and healthcare staff in general. The last thing I want to mention to you is our research program. We are slowly and steadily building our research program, and we're doing some collaborative studies. One of the ones that I'm working on is looking at using lithium as a way. In some ways, there's been some interesting data using small amounts of lithium may in fact prevent suicidal thinking, suicidal behavior, as you know, which is a huge issue. And we are part of that study. We're with the nationwide group. So that's one area we're working on. We have a couple of other diabetes studies that are coming on board and hypertension studies. So we have several research studies on their way so that we can advance science while we continue to do our critical care of taking care of veterans. So thank you for being here. Thank you for your service. And we'll, I think, move on to Chuck.
All right. Thanks, Dr. Comanduri. All right. So we got quite a few questions here. So before we get into that, just want to remind you once again, this is a moderated town hall. So Mr. Martinez will take. Ma'am, you can fill out a comment card and we will be happy to, this is a moderated town hall and our veterans have asked to have time for us to address their questions, We're not controlling anything, ma'am. So, all right, let's get to the questions here. So our first question is and this is something that Dr. Comanduri and I recently talked about. It actually came up in one of our legislative sessions. Sorry, I'll pull the card out here. So this actually came up in the Nevada Department of Veteran Services legislative session recently. And I know the VA is kind of working on this, but there's still a lot of stuff that's out there. The question is will the Southern Nevada VA hospital use hyperbaric oxygen chambers to heal our veterans or members that are suffering from traumatic brain injuries? I know the VA has started some PTSD studies in Northern California and Oklahoma, but with specifics to TBI, do you know where the VA is headed with that or what the thinking is at the moment?
The VA actually recently released their preliminary review of use of hyperbaric oxygen. And again, we talk about research has to be done in an appropriate scientific way, which is what we talk about, a double-blind placebo control. So we essentially, one person gets the treatment, next person gets the treatment. Neither the person receiving the treatment nor the doctor providing the treatment knows exactly what's going on, and looks at what are the evidence, what are the results. So far, when you look at very strong objective studies, this has not yet shown, and the VA's national review says that hyperbaric has not yet shown to be saying something that is going to be proven in that kind of a double-blind placebo-controlled study. Having said that, that does not mean it doesn't work. So we can say there are instances. The problem is a lot of evidence right now is anecdotal. I've used it, it helps me. It may very well help folks, and we may find a subgroup perhaps that it would help. We don't know enough to say at this stage to say that is a proven regimen or treatment. So for the VA to get into it, it'll start actually more likely to be research in an academic center and slowly develop towards, if it's been proven there, then we may expand openings. So right now the VA is not looking at this as a wide open program that's easily proven at least.
All right, great. Thanks, Doctor. Ms. Dowdy, I have one for you. So, and I think this is kind of like a good education for any veteran. The veteran says that they have vision problems. They've been examined by an eye doctor, began wearing glasses when they're in the military. Do they qualify for any sort of service connection with that? And then kind of as a follow part, they were also asking about something with having to use a CPAP machine. So obviously that's probably sleep apnea related. So I think we probably just educate them on what the process is if they want to see if they can be considered for service connection.
What we look at in terms of service connection is one, an in-service incident, meaning we need to be able to relate the condition that you're claiming to your service. Two, so somehow we need to see evidence in your records unless it is a condition that has been deemed presumptive. Two, we look for continuity of treatment. So if we have evidence, if it's not a presumptive, that you receive, that you have, you went to treatment, it's in your service treatment records while you were in service, we look for when you return from service, did you continue to receive treatment? And so we look for the, again, in-service evidence, continuity of treatment, and then the diagnosis as well. So there are times where, you know, we have to weigh evidence when all those things aren't there. But that's the law. Those three criteria minus it being a presumptive condition. Thank you for that, adding that. So if you wanted to apply, and I always tell veterans that it's free. What do you have to lose if you don't know? Our job, we have a duty to assist you to get the information to help support your claim. So one, find a accredited representative or agent to assist you in filing the claim. Or if you're here in Las Vegas, please come right over to our VA benefits office, and one of my public contact outreach specialists or LASs will be happy to assist you with filing a claim. So you will state the conditions that you believe are linked to your service. We will ask you about where you received treatment over the years, and we will assist and go out and find and request that evidence from those medical providers as well.
Great, thank you. All right, we have two questions that are very similar here, and I'm going to throw this out to any member of the executive leadership team that might want to answer this or provide a good explanation. So the question is, and I believe this is more national policy than local policies, in reference to veterans being able to use ambulances and bringing them to our ER versus the nearest emergency room and that. So we have two questions that are kind of along the similar lines, but does somebody want to kind of answer what that criteria is? I know that level of care is one concern.
So again, ambulance it's a good point. I mean, veterans ask, you know, why can't I get to the VA in ambulance? So part of it is, what is the complexity of care that you can offer? Can we provide the full range of care? And I'll give you a good example. Just this happened last week. In fact, the other night I was talking to our chief of the emergency department. This poor veteran was in Arizona, was having a heart attack, okay? Drove past with his wife. He passed every hospital from Arizona through Nevada to this hospital. And I mean, I understand there's, fear, will it cost me co-payment? Will I have other expensive costs through Medicare? I totally get that. The tragedy here is that this is a way too far to travel if you're having a heart attack. I mean, we're not able to, we want to immediately quickly get into action so that you can get into a cath lab as quickly as possible. If we can, then if there's a clot, they can at least address it. And if they can do additional procedures, they can do that. If you need to put a stent in, they can do that. But waiting that long, time is muscle, right? You lose heart muscle. As you lose circulation to the heart, you lose that muscle, that portion of the muscle dies. The longer it takes, it's the worse it is. So important thing is, we are kind of in an unusual location where even though this area is growing, we're far away from kind of the center of the city. So there is one challenge of coming here. Part of it is we have to also develop some agreements with ambulances, what we can take. Clearly, someone who's in acute cardiac intervention shouldn't be transported farther away from their nearest hospital to get the care, whether it be ambulance or by family, right? Same type of things. Our stroke and all these conditions that you don't want to come in and say, oh my God, I've gone too far because I've done too much damage to my body. So we have to work, we're working and we're developing hopefully a process where eventually with that local ambulance to figure out a mechanism to take only areas that we're capable of managing. We don't have cardiothoracic surgery, so we're not able to do some of the complex, we don't have a neurosurgery. So somebody has a brain injury, we can't acutely treat those things. We're not a trauma center. So those are things that we can't do, we're not going to take. But hopefully in the future, we will develop a mechanism to take some of the straightforward cases that we could actually manage here through ambulance.
Dr. Strong?
Yeah, Dr. Commodore is absolutely correct. We are not able to perform or take those cases that are very high acuity, like a stroke or someone who's having chest pain, because we don't have capabilities of doing like open heart surgery. But what I would ask of you is that we're really nationally rolling out a program called, it's like Care Transitions, care coordination. And if you look in the literature, there's a lot of talk about that. And so what we're doing here is that if patients present out into the community hospitals and you let them know that there's a veteran, they'll reach out. We have a whole team of nurses that follow the patients who are out in the community. And then what we want to do is then bridge your care back into our healthcare system. So we want to know who's out in the community and what's going on and how we can help you get what you need. So when you go home, you have, maybe you need a walker or a bedside commode, or you need some dressing changes, or we need to get you some medications, or you need to have a nurse come into your house, or physical therapist. And so what we're working on here is to really develop a robust process and system so we can help take care of you from your stay in the community hospital back to home and then back into our healthcare system. So right now we're not able to take ambulances. It's because there's some limitations of services that we cannot provide, and we don't want you to show up and us not be able to take care of you. And then we have to send you back out into the community anyway. So, all right.
Thanks, Dr. Strong. All right, so the next question is in reference to pain management type questions. Yes, ma'am, if it's quick.
As a new resident to Nevada, and I was very surprised to find out that when you get a new doctor, civilian doctor, or you go to a hospital, they don't ask, did you have any military service? Wouldn't that be helpful in terms of this kind of care coordination if we asked our civilian hospitals and healthcare professionals if the person coming in had military service, even if it was just a little box to check off, because we need to start the conversation. Thank you.
That's one of the things that we can ask them to do. And, you know, they have great contacts. I'll just digress just a little bit. On October 1, when we had the shooting here in Las Vegas, one of the things that happened, which most people haven't really shared, is that all the hospitals really worked together to move patients out that could receive care in a different level so that we could make sure that those who needed acute care, had acute care needs, were bedded. And we moved patients seamlessly across the valley. And that's that care coordination that's going on. But that's a great suggestion, and we'll add it to our ask to the community hospitals.
Thank you. And
If, I was going to say, if I can add that on October 1, really the VA folks, we have a lot of our mental health staff, nurses, health doctors, social workers, psychologists stepped up and went out and worked with the local community, whether the people that the VA took care of was veterans or not. They stepped up and helped the local hospitals deal with the tremendous trauma, so they helped out. The other important thing, interesting thing we've established, actually, our suicide prevention coordinators have actually established something what you talked about. They've established agreements with local mental health hospitals. If a veteran somehow gets admitted to that hospital, they communicate to us so we can make sure we can incorporate them back into the VA system.
thanks, Dr. Commodore. And just a reminder, this is something for all veterans. Whenever you do go to an outside, like an emergency room, you need to let them know or notify the VA or have your family member notify the VA within 72 hours that you're a veteran, and so that that care can be followed. So that's an important thing to remember as far as educating yourself on your care, is make sure somebody does let that emergency department know you're a veteran. Okay, the next question is the one question we get at every town hall, and I think this is a good question to kind of bring up right now, because we've actually done a heck of a lot since the last time we met in this area. So the question is in reference, it gets asked in 27 different ways, but the question is nobody ever feels like there's enough parking at the VA. This one was specific to handicap parking, but Ms. Kearns, do you want to talk about all the different parking things we've done?
Well, it just really, since the last town hall, we've added about 135 parking places, and that has allowed us to move all the government cars that we use to go out and visit veterans into one lot, so they're not taking up slots where veterans could park. So that's one. We have valet parking here at the west entrance. We've recently added it to the east entrance, so it wasn't offered at both. So that's another thing we've done with parking. And we do have some plans to add some more parking in the future. Not the so far future, but we know that we keep growing, and so that is always a concern for folks, is where can we park? Well, actually, we have more handicap parking here than we're required to have. And so it's something we always look at. At the clinics, they don't have as many people going there, so it appears like they have plenty of handicap parking. We see about 2,500 people a day here. So it's difficult to have all the parking that we want to have. But the good part is nobody has to pay for parking. A lot of VAs are in urban areas, and the veterans have to even pay for parking. So we're going to continue to look at our parking situation. We're going to continue to try to add more spots as we can do that.
Just a couple other things on that. Ms. Kearns did mention, for the handicap, that valet parking that we have now in 3 locations, to include the emergency room. We do have during certain hours there as well. And then also the employees, we used to kind of, because we were waiting on some parking to get finished, now the employees are being forced to park in the backside of a hospital in certain areas too, so that there's more parking up here in the front freed up for our veterans as well. So our police chief's happy to ticket them if he sees them out there. So so we are working that issue. So. All right, so this next question, Dr. Commodore, is kind of pain management related, and it's kind of a 2-part question. The first part of the question is, and like I said, I wish Dr. Asani were here today. He kind of is a pro on these things, but the question is why is chiropractic care limited to 3 months? Kind of the comment is the body's a machine like a car, which needs a periodic alignment. That's just part 1 of this. And then part 2 is the person was asking about full body acupuncture. How do you get full body acupuncture here, like they gave this individual at another facility the individual feels like the battlefield acupuncture isn't quite as effective. So can you touch on those?
Sure. A couple of things. Sometimes chiropractic care, certainly it has value and benefit, and we are working actually to add additional chiropractic care benefits. One thing is our pain management program here in VA Southern Nevada is considered among the best in the nation. It's actually a model that the VA central office is looking at, the National Pain Management Program, and looking at ways to expand it to other facilities across the country. So the Dr. Isani, our acting deputy chief of staff, is also chief of pain program here. Dr. Isani has done a tremendous job of building the program. We offer every complex intervention, all the way to intervention and implantation, to more surface care, including acupuncture and of course chiropractic care. We also do osteopathic manual manipulation, which is an OMT, which is done by osteopathic physicians, which is similar to that. We also offer yoga and Tai Chi. So we have lots of other programs. So the issue of how long should you have chiropractic care? So the VA has taken the data looking at the evidence base. We talked earlier about double-blind, placebo-controlled, evidence-based care. So most instances, it is the time-limited approach is what is recommended. So now that doesn't mean some people don't need more chiropractic care. So we have to look at it's individualized to take a look. Not everyone needs chiropractic care all the time, forever type of thing. So we have to really individualize to the patient. We also use other programs. We have Alpha Stim, which is a program that has been very helpful to many veterans with pain. So that's another thing. Please explore when the person who asked this question with your provider, Alpha Stim as an opportunity, which could be used at home. So that's a next program to look at. So that's the chiropractic side. So we'll continue to add and expand that service, and we were going to actually have chiropractic trainees. So we'll do more. But it is important to know that the data supports more time limited rather than essentially lifelong. So we will look at each step of the way. In fact, some of the chiropractors, experts we've looked at have actually did recommend it should be more time limited. So that's the guidelines we've used. With regard to full body acupuncture, we do have full body acupuncture available here, but we only have one full-time doctor and one doctor part-time doing full body acupuncture. And that's an area we hope to grow too, because it is highly in demand, but it is a program that's available to us. It is available. Please check with the pain clinic or wherever you're getting your auricular acupuncture.
Great. Thanks, Dr. Comanduri. So this next question is reference to the question says this, and I know that we probably have to ask our Nellis partners about this a little bit more, but it says retired military had the option of using the Nellis facility, but they now have, they only service active duty only. Are you aware of this? And is there ways to accommodate those vets, or is this an added burden to the VA? I haven't heard that Nellis is not accepting retirees, so.
I haven't heard of that. I mean, some of the veterans that I see actually who are retirees come to the VA here and they still go to Nellis. So now the issue lately more is about the gate, because they are enforcing a higher security standard, and if you're not a retiree, it's somewhat more challenging to get on.
Yeah, so we have a quarterly meeting with the Nellis medical leadership. We can ask them that question on Tuesday. But if you're a veteran, you can, you can enroll in, possibly see what benefits are, and possibly enroll in healthcare depending on the rules and all that. So we will ask that question. Okay, this next question is in reference to something Secretary Shulkin said in the November timeframe, and this is for you, Ms. Stouty. In November, he had referenced, he said that the VA was considering granting presumptive status to additional medical conditions for Vietnam veterans who were exposed to Agent Orange. Have you heard anything on that, or any information or updates on that?
No, there was some traction for, I would say, about a month and a half or two, but we did not receive any updates on that yet.
Okay, unfortunately. And then just kind of a part two is, this is one that's come up at town halls too, and It's actually come up. It's more of a VBA side than that. Is in addition to Agent Orange, we have a lot of veterans, particularly Marines, who are stationed at Camp Lejeune between 1957 and 87. That they're being asked to come to the VBA, and we've gotten a lot of questions on that process. If you're somebody who's at Camp Lejeune, kind of what is that process to look at?
So what we look for in terms of service connecting veterans that were exposed to the contaminated water, that you were during the exposure period, and the time frame we look at is 53 to 87. We also, you have to be active duty reserve of guard with a cumulative of 30 days served between that time period. So those are the three benchmarks we're looking for. Okay, and again, if you believe that you meet that criteria, we do ask you to get with your accredited representative or agent, or please contact us in one of our public contact offices or online, www.va.gov, and you can submit a claim. Okay.
All right, great, thanks. And just kind of a follow on the healthcare side, obviously all of that goes through the VBA side. But if you've been kind of determined through the VBA side as a Camp Lejeune type veteran, is please, when you're meeting with, if you're being seen for one of those types of conditions, you're meeting with our healthcare providers, remind them that you are a Camp Lejeune veteran, so that's put on your records. We've had some cases in the past where people have been received co-pays or bills for care that they shouldn't have. So make sure that we get that on your records when you're being seen. Okay. So, Dr. Commodore, I think this one is for you, and if we can educate the staff here, it's kind of a two-part question. The first part is the individual was trying to see a specialty clinic, GI clinic for handling. He got a consult from primary care, and according to the individual, they refused the consultation 90% of the time, and the individual, it's a service-connected condition that the individual is trying to be seen for. What recourse does a veteran have if the specialty care doctor is refusing the primary care consult?
Well, so if you look at part of it, gastroenterology especially has been very difficult for us. We actually hired somebody, one more doctor. We only have 2 gastroenterology doctors. The doctor we hired, we've been waiting for 6 months, and last week he said, well, I'm not going to move to Nevada. So there goes that opportunity. It has been so difficult to recruit. And so a lot of our gastroenterology care actually goes out care in the community, goes out into the community, unfortunately. And veterans generally are not necessarily happy going out in the community. They prefer to come here. It's a matter of us building capacity for GI. It is a very, very difficult area to recruit and keep in this community, and it's getting to be an issue across the country. But in a case where you say, I have a need, my specialist doesn't doesn't need to see me for whatever reason, they say they have my primary care says they need to. This is an area really that's a conversation between the specialist and primary care. And if there is a significant disagreement, it actually a lot of times comes up to my office and we figure out how to address that. So if your primary care is having these challenges, it's not uncommon that they'll come to me or go to the chief of primary care, and then we'll sit down with the specialist to figure out how to best explain and describe the reason for it. So we'll work on that between the specialties and communication.
Seeing whether I had said, there's records going back to 1969 saying I had said I have been treated in the VA for years about this condition. I was a bad boy when he failed, was treated there. He gave them records of 2,000 pages on that treatment.
Okay, sir, let me do this.
It was wasted money on the test. See if I even had a condition.
Well, let me talk to you after this separately, see if I can better understand this, all right? Thanks, Dr. Dick.
All right, so we're just kind of going through, see if we got all of our questions that were addressed to you. and to see if any of my, all my online questions were